This lecture is about infectious arthritis. We know that inflammation of the joint is called arthritis, and this is an observable finding. However, when we have pain in a joint, which is called arthralgia, that's really a subjective description. One important type of arthritis that we are focusing on is infectious arthritis, and that's really considered a medical emergency. So your assessments, history taking, interviewing, assessment, physical exam skills have to be very astute so that you can discriminate and differentiate and then identify these issues. So the cause of infectious arthritis can be from a bacteria, a fungus, a virus, a filera, which is really a parasite. When you hear the term septic arthritis, they're really describing a bacterial pathogen, and I think that's important to know. The other thing that Butera points out in our text is that don't let a personal medical history of someone that has rheumatoid arthritis or gout or a joint replacement, don't let that lead you into not considering that they could also have an infectious arthritis, because those things actually increase the likelihood that they could develop an infectious arthritis. So bacteria and virus, viral infectious arthritis really manifest acutely. They have with both systemic and articular symptoms. So you're going to see a fever and malaise and fatigue, and then you're going to see pain and swelling and redness and limited mobility in that joint. When you take the consideration that Lyme disease, mycobacteria, fungus or filaral, and then some other bacterias, those presentations might not be as I just mentioned above with the common bacterium and virans. They really might be subacute or even a chronic problem within a joint, or indolent, just really not very striking. So be quite aware of the differences. Those are cues. The epidemiology of infectious arthritis is seen in all age groups. The highest incidence is in children and elderly, immunocompromised. And then when a person has an abnormality of a joint or a joint replacement, please recognize this puts them at an increased risk for infectious arthritis. The pathogenesis of infectious arthritis is that most of it occurs in the synovial joints, the hips and the knees, and they're very vulnerable to infection, especially, again, with the abnormal joints, say someone with RA joint or a prosthetic joint. The rationale behind that is that synovial tissue is highly vascular, and it also lacks a basement membrane, so dissemination of that infection is quite easy within these synovial joints, unfortunately. Other sources of infectious arthritis might come from someone who has osteomyelitis, maybe some adjacent soft tissue infection that's not been treated, or how about direct inoculation, so a foreign body from trauma. The two most frequent causative agents is Staphylococcus aureus. That's the number one, and in all age groups. And then streptococci is the number 2 pathogenomic cause. Interesting that those are both just normal skin flora. Okay, so that you keep in mind. In contrast, when you see a joint that's infected with gonorrhea, you then can remember that this is the most common cause of infectious arthritis and sexually transmitted infections. This is going to be seen much more frequently in young sexually active adults under 30. Clinical presentation includes acute onset of a painful red swollen joint. It's warm to touch. The affected joint is painful at rest. That is a huge flag. Um, as with range of motion or weight bearing, but that with rest is what can alert you to infectious arthritis. Fluid volume and a rise in the intra-articular pressure is what creates that rest pain. And I'll talk a little bit about effusion and infusion size, but just depending on how large it is. Fever is present most of the time, but in the elderly, they might have a low grade or an absent, no fever at all. They may have the rigors. Hip and knee is the most commonly affected. I told you that because they're synovial joints. Polyarticular septic arthritis is seen with streptococcal infection. So that's a cue. Seeing multiple joints, not just one joint, you think streptococcal versus, say, Staphylococcus aureus. We do know that septic arthritis or infectious arthritis occurs mostly in immunocompromised persons and those with pre-existing joint abnormalities. Fever and joint inflammation are less striking in gonococcal arthritis, so keep that in mind when you're assessing someone that clinically presents. Physical exam, you're going to see an inflamed joint. It's erythematous, warm to touch, swollen and painful with rest or passive or active range of motion. That synovial fusion is usually present. If it's a large effusion, it'll cause deformity of the joint. It can be quite impressive. If it's a small effusion, you might not even be able to palpate it or see much of a deformity. Decreased range of motion, muscle spasm, and apprehension to joint exam are quite prominent and should alert you. And then be sure you're assessing the entire extremity and into the proximal lymph node area. That's typical to find that they're swollen and tender. Gonococcal arthritis, again, is the most common in young sexually active adults. There can be a triad of symptoms, dermatitis, tenosynovitis, and migratory polyarthritis, and be aware of that. Interesting that people that have joint replacements, prosthetic joints, about 1% develop an infectious arthritis, and they typically end up having to have that joint removed and are on long-term IV antibiotics, about 6 weeks. You can look at early infectious arthritis, delayed or late. Usually early and delayed are related to the joint replacement itself. And then the late prosthetic infectious arthritis is usually coming from a different source. Lyme's disease, really what I want you to just do is have that in your differential, asking about tick bites. Not all people are aware they've been bitten by a tick. And do know that almost all of the patients should respond on a Lyme ELISA test. Better outcomes with earlier treatment, so that's got to be in your differential, and you can look at that in their blood work. Injection drug users have unusual presentations and unusual organisms. You should alert that provider to an injection drug cause. Although MRSA does continue to be the most causative pathogen, that methicillin-resistant Staphylococcus aureus. Septic sacroilious really can be elusive because there's some non-specific symptoms, but think fever, low back pain, and gluteal pain that's worse with ambulation. Diagnostically, we can look at CBC with DIF to differentiate bacteria versus virus. ESR and CRP is giving you some inflammatory markers and peripheral blood smears. In that younger patient, when you think they could have gonorrhea, you've got to get all of those, pharyngeal, rectal, cervical, or urethral cultures. Synovial fluid culture through aspiration is a very important part of diagnosing. Radiographs aren't usually used in early infection, but they might be helpful with underlying arthritis or osteomyelitis. Musculoskeletal ultrasound is useful, and CT, MRI in difficult diagnostic situations, but those would be people I'd have already referred anyway. Management is hospitalization, early IV antibiotics, and drainage to required treatment of infectious arthritis, and sometimes you have to redrain daily. If greater than 7 days is delayed diagnoses, then the prognosis for a functional joint is poor. We usually see our patients being started with a broad antibiotic, and then when the culture results come back, the antibiotic can be individualized. Look at those specific treatments on page 944, 945. And also review that ceftriaxone selection when we make that selection. Daily drainage until inflammation is resolved, I had told you about. Referral. An infected joint is a medical emergency. All patients with infection arthritis should be hospitalized and should adhere to non-weight-bearing daily joint aspiration or surgical intervention. Really often we're referring these patients to infectious disease, rheumatologist, or orthopedist, and PT should be part of that interdisciplinary treatment, both in hospital and once the patient goes home as needed. Patient and family education. They really need to know that all dental work and wounds or ulcers should be healed before any joint replacement. So if they're going to have any major dental work, that needs to be removed from joint replacement. Antibiotic prophylaxis prior to surgery is usually given, although there's some controversy about that. And antibiotic treatment before urology or in gastroenterology or dental procedures. And again, read about the controversy. They really need to be educated that immune compromise is at increased risk for arthritis. So our patients that are on drugs that reduce the immune system or have a disease, wound and ulcers need immediate medical attention so that they don't lead to septic arthritis, and PT at home to prevent loss of motion and function. Thank you.